Good afternoon, everyone. Welcome to today's webinar. I would like to request our Dean and Senior Professor, Professor Prabha Chandra, to start off with the webinar.
Thank you, Chetna. And my name is Dr. Prabha Chandra, and I'm the lead for this whole project on Center for Violence and Mental Health at NIMHANS. I just want to tell you a little bit about the center before we start off on today's talk. First of all, thank you to all of you for joining. We've had an overwhelming response, and we hope to see you all again. So the idea is to have monthly webinars, both in English and in Kannada, on topics which are related to violence against women and its association with mental health. And we thought it was important to start off in this month of September to talk about self-harm and suicide, because as we all know, September is the Suicide Prevention Month, International Suicide Prevention Month. So what does the COE stand for? So basically, the Center for Excellence was an idea which stemmed from policymakers in the government of Karnataka in the Department of Women and Child Development. So this was an initiative which was started by them. They recognize the importance of mental health in women who face violence. And the center is actually a collaborative effort between the National Law School of India, University, Bangalore, and NIMHANS, Bangalore. So the National Law University looks after the legal issues, and we look after the mental health issues. So the aims and objectives of the center.
Ma'am, you got muted, ma'am.
Yeah.
Okay.
Can you hear me now?
Yeah.
So basically the aims of the vision and the aims of the COE are to create a repository of resources for anyone who wants to needs them or support women who are facing violence and are interested in looking after their mental health. So we are creating a whole range of resources. We already have many resources, and later the organizers will put the links onto the chat so that you can access these resources both in English and in Kannada and also in Hindi. We also aim to conduct action research, particularly in marginalized populations and difficult to reach populations who face violence, such as domestic workers, migrant populations, and in women in remote areas. We also are very committed to listening to the survivor's voice, and to have women with lived experience of violence informing many of our activities. So in our advisory group, we have women who have faced violence, who tell us about what they would like research to be on, how they would like services to be delivered. And finally, one of the major remits of our COE is to train stakeholders at various levels, not just mental health professionals, but police, judiciary, health workers, health professionals, and NGOs in this important aspect of mental health issues. So it gives me great pleasure to invite the two speakers for today. Firstly, Dr. Aruna Yadail, who is a professor of psychiatry at Father Muller's Hospital in Mangalore. She is somebody who has been working in the area of women's mental health, has written chapters and papers on suicide prevention in women, and is going to take us through this important area of what is the relationship between self-harm, suicide, and domestic violence. We then have Dr. Veena Satyanarayana, who is additional professor of clinical psychology at NIMHANS. She again brings a huge, wealth of experience and years of experience of working in the field of violence against women and the mental health aspects. And she will be talking to us about interventions, psychological interventions, which can be done to either prevent self-harm from happening or to prevent a recurrence from happening. Because as you'll hear, the rates of self-harm among women who face violence is quite high. So the idea is that we listen to both the speakers, And then, we would encourage the audience to ask questions. May I request all of you to please put your questions onto the Q&A box or the chat box. The moderators will keep collecting the questions and will inform the speakers, and we will have that at the end. We will try and respond to as many questions and answers as possible. If not by the speakers, then through the moderators. So without much ado, I would like to invite Dr. Aruna to talk to us and take us through this whole area of the relationship between domestic violence, suicide, and self-harm. Dr. Aruna.
Thank you, Dr. Prabha, for that introduction. Actually, I want to thank the MITHANS and the COE of the this VAWH, the new thing what you have brought. And I think the only qualification for me to be here invited is I am unabashedly a feminist. So any violence against women is a big no-no. There is no excuse, or there is nothing that justifies violence against women. So probably as an unapologetically feminist female, probably I am more qualified, because all psychiatrists deal with self-harm, especially in women, day in and day out with clinical practice. So maybe I would. It is a topic more close to my heart. That is what I can say about it. So without much ado, I thank Dr. Prabha ma'am, and I eagerly wait to listen to Dr. Tina also about this topic. So I will start sharing my screen, because there is a lag of what I'm telling and this. I will stop sharing my video and start sharing my screen. At the end, I will come back on the video. Is that okay, ma'am?
Yes.
I will just switch off my video for now. Am I still audible?
Yes, you're clear and audible.
When I'm shooting across the time, please, I would want either Dr. Chetana or Krishma to just remind me that I have less minutes. I will try to go on with a good pace. So let us see what I have to tell today. Risk of self-harm among women facing violence. It's almost a thing, like when it comes to self-harm in women, most of the factors or the risk factors points towards that they have faced so much of adversities in life.
Ma'am, just
One of
a
the-
minute. Can you please switch on your slideshow?
Okay. Which one? Yeah. Is it done?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Perfect. Thank you.
Okay. When it comes to the risk of self-harm and women facing violence, when we study about self-harm in general in women, most of the things we see that it is that violence and self of risk harm is very much connected, and it might not be, or it might be connected with suicide, but knowingly or unknowingly they risk suicide a lot among this population of women also. So, when it comes to introduction, what I be speaking about in this topic is a little bit introduction about gender-based violence, statistics, and impact on how it is going to affect women. Self-harm in women, what are the synonyms or the prototypes and the definitions? How the WHO and the NICE definitions are a little bit too wide and too narrow, and the relationship between self-harm and suicide, and the risk factors for self-harm, all of us know it, and what function the self-harm serves, or what are the ends of self-harm. There is a little bit one slide on neurobiological links. I wouldn't want to elaborate much on it, because there are I wouldn't want to focus too much on the academic part of it, and a little bit of how to about a conclusion regarding the topic. So, coming to gender-based violence, it's one of the most prevalent human rights violation as well. It's not more of a public and a social topic rather than a medical topic, I would say. And whatever the developed countries or the educated or the so-called civilized nations boast about it, the gender-based violence has shown that it has no social, economic, or national boundaries. Yes, it is more prevalent in the underdeveloped nations where there is more of gender inequality, but no nation can boast that it is free of gender-based violence, and that's a sad telling of our times. This is the WHO data of as recent as 2021. One out of three women are subjected to violence worldwide. And that stands at a very big number. 736 million of us women are facing it. And you can see that it is so pervasive that it has keeping up with the times very badly, occupies digital spaces too in recent years. So that kind of violence is also there. Cyber violence. Without touching a person, you can harm that person, and that person is driven to self-harm or even suicidal attempts. So, what is the impact of this gender-based violence on the mental health of women? It obviously it undermines the health, dignity, security, and the autonomy of its victims, but it still remains shrouded in a culture of silence. The moment we start speaking about gender-based violence, there are voices telling that already women are empowered. How much more empowerment do you want? These days, men are afraid of women. What are you telling? So, when the violence is based on gender, it might be men, it might be women, but the statistics show a very skewed proportion telling that women are more of the victims. And this doesn't mean to say that men should be victimized more. It doesn't mean that at all. We are telling that because gender is used as a determinant in lashing out with violence, maybe that is where we have to work like why it is so. So it remains shrouded in a culture of silence, but it has long and short-term consequences for women. All the physical, mental, even sexual and reproductive health is compromised. The major sequel which has been reported, and there are much more unreported things also. Injuries, unintended pregnancies, sexually transmitted disorders, gynecological disorders, anxiety, depression, self-harm, which we will be talking today, and fatally it may end up with suicide also. The problem is not just with the health or the mental health sequel of women undergoing violence. The impunity of the perpetrators. We see it daily in the newspapers. In the Bilkin Bano case, the perpetrators are garlanded and lauded. I don't know for what. And the fear generated thereby has effect on all women. You may be subjected to violence or you may not be subjected to violence. But this kind of impunity of the perpetrators and thereby the fear generated, it has an effect on all women. And that takes a toll at a global level, which turns the contribution of all girls, all women, somewhere, everywhere. So they don't contribute that much as their potential allows them to. If you see the labor force, the percentage of women working is very dismal. It is less than 25%. So for them to become empowered, I think this fear of violence also is a big factor or big thing that matters to all women. So self-harm in women, what is otherwise called? You can call it by several names, though it will mean or it will have the same impact kind of thing. Self-injury, self-poisoning, self-mutilation. It is also called as para-suicide in academical terms. Deliberate self-harm is what we call in an abbreviation form. The global prevalence is, there are various studies. There was a long meta-analysis kind of study which we looked at a 10 or 12-year-old study from 2010 to 2021, where the prevalence ranged from as less as 2% to 22%. It was more definitely in young girls and women, and probably there was underreporting in the older population, 2.5 to 19.7%. And people, this is just the statistics of self harm. But if you connect the self harm with the violence, like victims of violence, women with history of intimate partner violence had 2.82 times higher risk of self harm. That is, they are 3 times more likely to harm themselves. There might be many psychological reasons behind it, which we will come to later. To put in a nutshell, almost 50%, that is 49.7% of this self-harm or suicide attempts, if we try to look from the other end, among women had past history of being victims to violence. This is from the NCBI data from Lancet Psychiatry as recent as 22. And I came upon a very good chapter on this where Hannah Picard tells about this, the self-harm is also a type of violence where the victim and the perpetrator are one. Usually when we visualize or we envisage violence, we think that it is an act done from one person towards the other. But here in self-harm, what happens is it is also a type of violent behavior, but it is the perpetrator and the victim are one and the same. Though indirectly the perpetrator might be someone else, we don't know. But the act itself, a victim and perpetrator of one might be, the self-harm might be seen as a kind of violence also. There are many definitions, and it's not easy to define self-harm as we define suicide. The suicide itself is a definition. Su means self and side means dying. So it is there in the word itself. But it's not as easy to define self-harm. The WHO, as back in 1994, has defined it as an act with non-fatal outcome in which an individual deliberately initiates a non-habitual behavior without intervention from others, and this is supposed to cause harm to self. But if you look at it, it is like too narrow a definition in the sense that um, why intervention from others not has become a uh, part of the definition. This definition aligns with the common usage in its focus on the deliberate nature of self-harm, but is unusual in its claim that self-harm is a non-habitual behavior. But because we see that self-harm is often a habit, a repetitive pattern of behavior, and there are instances where some people self-harm themselves daily also. So we can't, tell that it's a non-habitual behavior. Um, so it is unclear why an absence of intervention by others is part of the definition at all, and it kind of actually removes the possibility of self-harm fundamentally on such non-intervention, and it depends fundamentally on the self-harmer's own agency also. So if you see it together, the WHO definition appears to be too narrow because it keeps excluding many other things, whereas the UK definition or the NICE definition, which was revised again in 2011. It defines it as in stark contrast actually. It defines self-harm as the self-poisoning or self-injury irrespective of the apparent purpose of the act. So here you can see that the motivation for this removal of intent is in all likelihood a desire to accommodate forms of self-harm that stem from unconscious or unrecognized motives or impulses. Because that may be foreseeable or it is not directly intended. So this definition is actually too wide and it widens the scope of self-harm. Like for example, it can potentially include, where it is not deliberate, like in anorexia or eating disorders or substance use or risky sexual behaviors, even fights or getting into contact sports or extreme sports, where there is significant risk of physical damage, but that is not the apparent purpose of the activity. So if you see all that, we feel that the WHO definition is too narrow, whereas the NICE definition appears too wide. But there are many prototypes of what we call a self-harm. When you come to clinically telling about it, there is some prototypical forms. It includes cutting, scratching, stabbing oneself with sharp objects, burning with a lit match, or with a sharp object, smashing one's body part, banging the head, punching, self-hitting, carving words or symbols, piercing the skin, inserting objects under skin or orifices, swallowing blades, overdosing on illicit drugs, alcohol, even over-the-counter medicines, taking poisons, toxic substances, tying ligatures, partial hand, shooting oneself, throwing under vehicles, trains, off buildings. All this can be part of, or forms of self-harm that we usually see. Is there a relationship between suicide and death? Definitely, it is associated with a 50 to 100-fold increase in risk of suicide. And if we see one of the ends or one of the functions of self-harm might be suicide, maybe it's on a continuum. And the major distinguishing factor might be in versus self-harm versus suicide is the intent to die is not there in self-harm, whereas they very starkly in suicide. But the distinction might be very unclear, because self-harm victims might themselves be unsure of their intent. Or once they decide to self-harm themselves, they might be indifferent to the consequences or quite reckless. They don't care what happens later. So, knowingly and quite wittingly, they do risk death and suicide more. That is what we can say about self-harm and suicide. Though the intent to die is not classical of self-harm, but rather it's suicide. There are some risk factors or there are some vulnerable groups which makes them more vulnerable to this kind of things. The socio-economic or the educational factors are the most prominent one. Our cultural and folk psychological resources help us to make sense of self-directed violence or self-harm sometimes. But we also know that there are various associated factors, and you can see one of the major socio-economic risk factors is being female. So self-harm in those victims are more younger age group, definitely lower socio-economic status. Those belonging to LGBTQ community also have self-harm as more of a risk factor, lower educational achievement, exposure to similar self-harming peers. So these things act as risk factors. If you see in the psychiatric disorders or psychological factors, psychiatric disorders like personality disorders, depression, anxiety, ADHD, PTSD, Eating disorders. If you see, 5 out of the 6 psychiatric disorders are again more common in females. So again, the female predisposition towards self-harm is more. Alcohol and drug use disorders, impulsivity, some traits like low self-esteem, low self-worth, poor social problem skills, even some traits like perfectionism or a sense of social isolation. These things also can act towards as a risk factor for um, self-harm. There are some other factors, individual negative life events and family adversities where there is parental separation, people coming from broken homes, parents where they are divorced, family history of psychiatric illness, parental death at an early age, interpersonal difficulties, childhood bullying, and adverse childhood experiences, especially physical and sexual abuse. So if you see, all the risk factors also point towards the same group where people are subjected to violence, then they have this risk of they become more vulnerable and they have the risk of self-harm and suicide in them. So what does this self-harm serve as a purpose? What is the function or the end of such behaviors or this? Just like violence, it also has or serves it might be a means to some ends, and some of the ends it serves, self-harm is, one is affect regulation. They say that like violence towards others, it may be a way of managing their strong emotions, perhaps anger, rage, or shame. It can offer relief in various ways by distracting from emotional pain, by replacing it with physical pain, sometimes as a providing as a way of expressing, releasing, or acting on anger and aggression. And sometimes, contrastly, people may feel that in the face of some dissociation or emotional numbing, which might be part of the psychiatric state they are in, it can offer short term relief from negative emotional experience of various forms. So, it might act as a coping mechanism also. Whether that's a wrong coping mechanism or coping mechanism gone wrong, that is yet to be, subject to speculation again. Second purpose, it may serve as a self punishment kind of thing. People who have already internalized, or women who have already internalized negative attitudes towards them, and most probably they have a history of mistreatment, typically leading again to extreme low self-esteem, low self-worth. Sometimes they themselves tend to believe that they are bad, deserve to be harmed. So it can be both expressive or often explained by such negative self-directed attitudes, like they feel that their kind deserve to be punished. The third end or the means might be, it's a way of communication. It can be to communicate internal distress by symbolizing emotions in concrete or physical form. So one of the statements or sentences that I read stood with me was this, public expression of a private pain. So is that what they are trying to tell us? They can't express their pain, so this is how they express it publicly. People who come from backgrounds of socio-economic adversity may struggle to identify. They may not be able to verbalize, talk about their feelings. So self-harm will provide a powerful way of demonstrating what they are going through. Potentially thereby might be they are seeking care and help. So it might be at the end of the day what we say, for suicide, like it might be a cry for. The other thing is the other punishment, where punishment is directed towards others, but the self harm is done towards self. So it is natural for women as much as men, though the cultural stereotype will tell us that women are not supposed to get angry. We are supposed to be the best Shamya, the Ritris of the world, and they're supposed to forgive everybody, not feel anger. But yet women do feel anger and rage, and they can be aggressive and violent towards those who have harmed either them or those whom they care about. So, self harm can offer a safe way of expressing such emotions and impulses when violence towards others is deemed unacceptable. They are very angry towards others, but hitting them out or lashing them or harming them might be impractical, or they can't do it because it's illegal. And this function of self harm correlates with the experience of being attacked that self harm can provoke in others. So, it kind of becomes like a symbolic weapon, turning anger towards others, but it is directed inwards on the self, but yet they tend to communicate this anger to others, like whom they are directed towards. It becomes like a symbol of anger towards others also. Another is a sense of control. So, it can create a sense of empowerment and control by establishing ownership of one's own body, especially if it happens when they feel that they are feeling helpless and being violated. Again, this has a childhood history of physical or sexual abuse. So, for people whose bodies have been harmed by others, it can be an act both of reclaiming their body and also to use Anna Freud's concept, like a defense mechanism, like identification with the perpetrator, establishing that it is they and no one else who has now dominance or control over their body. So, from a range of feeling hopeless, they want to show who is in control, or to get that sense of control, they might be self harming themselves. Also, as a desire for death, even though that is the distinguishing feature what we keep from suicide, it can be on the continuum of suicide and when associated with mental health problems, especially the desire to kill oneself is typically understood as expressive of hopelessness and despair, as a desire for permanent escape. In contrast to this, sometimes self-harm offers a short-term relief. It can also be seen as an act of hope that came as a surprise to me, where Anna Morse in 2009 in her paper reports of a first-person report, where she has put down the note of person where they tell that I needed to kill something in me, this awful feeling like worms tunneling along my nerves. And when I discovered the razor blade cutting, if you will believe me, was my gesture of hope. So we always tend to think that it's a sign of hopelessness or worthlessness. It might be quite the opposite for the person who is doing that self harm. So I drew the line in the sand, marked my body as mine, and its blood is under my command. So that is how he or she has told it. He is a report of a female. So the self-harm in female might have various dimensions. It may serve many functions other than this also. So this is one of the neurobiological things which I came across, and this is from a book also, Suicide by Self-Immolation, which Dr. Prabha is also one of the authors. So in that, I found a chapter which connects the trauma, the adversity, the self-harm, and the violence. So the relationship between early trauma, violence, and pathogenesis of both suicide and self-harm is actually multifactorial. It includes many things like even the epigenetic factors like the allostatic overload or the DNA methylation, which is very common in such epigenetics and all. But the one sentence which stood with me was adversities leave behind biological memories. So they are trying to tell that it alters the epigenetics or the way the genes express, and might make females more susceptible or more vulnerable to illnesses. And it doesn't mean just physical illnesses, the more the mental illnesses also. What they are probably it may help unmask certain things. So factors such as intergenerational transmission of trauma, early life adversities, violent re-traumatization of the same during their young adulthood would cause epigenetic changes that place women at risk of self-harm and suicide, which may end fatally, more so for women. So, to conclude, I would say that when we see all these self-harm and adversities, especially people who have undergone violence and those kind of things, and they ending up having self-harm and suicide as one of their options, it is a harrowing indictment on our society and culture itself. At one end, we tend to put women on pedestals and tell that without women, they are worth worshipping, but it's a harrowing indictment on our society itself that women suffer such adversity, trauma, and abuse, and are possessed of so few genuine perceived alternative options that they choose to be violent towards themselves, just like a way of coping with and expressing their experience. They should have had better choices, and that choice was not provided by the society. That's an indictment of our society, of our times, of our culture. And women who self-harm seem not to treat themselves with the respect and equality that they, along with all others, are due or they deserve. But they are not treating themselves so. So effectively and ethically, if we want to address self-harm, not just clinically, effectively and also ethically. There are two interwoven facets, I would say. One facet looks to the rational agency or the concept of the woman having some control over her behavior. That is the self-harmer herself, the need to support and empower her to choose self-care over self-harm. Whatever happens, you have to be kind to yourself. You have to see yourself in a better way and rise above that, feeling of worthlessness or shame or whatever it is that they are facing. The other facet definitely has a larger impact, and also it requires more efforts from the society also. The other facet looks to the context of adversities and oppression in which women are situated. And the change and the society has to change the ways they are treated in wider society and options available to them. So unless we do that, probably nothing else can be done also. So I, I I cannot elaborate on these factors because that is what our next speaker is going to speak about. So from here on, I will give it to next speaker and Prabha ma'am, and probably the questions will be handled at the end.
Thank you so much, Dr. Aruna, for mentioning some very important key issues. The first being the high rates of self-harm among persons who have faced violence. You mentioned that nearly 40% of people who come with self-harm have had an experience of violence, particularly women. I think also emphasizing that sometimes it may be a cry for help. Sometimes it may be a way of controlling one's emotions because you can't do anything else under those circumstances. And how, while we may say that it's self-harm, it's cutting, it's hurting, many times it may also escalate and lead to serious forms of self-harm. So it should not be taken very lightly. Because one of the things that happens, and we see this quite often, particularly when cases of domestic violence go to court, that the family which is inflicting violence often says that she's dramatic, that she's mentally unstable because she's attempted suicide. They sometimes have these documents which mention that she's tried self-harm and kind of use that as a way of establishing that she's unreliable and that she's emotionally unstable, and hence then the violence is not taken very seriously. So I think there are huge lessons to learn from your presentation. I'm sure there are quite a few questions on chat, but like we said, we'll take some of these questions later. Thank you very much for covering that difficult area so beautifully. And we hope that at the end of this, we will come out with some sort of methods by which we can mitigate. So I'm going to now hand it over to Dr. Veena Satyanarayana to take us through some of the interventions that are possible. Dr. Veena.
Thank you, ma'am. Just give me 1 second to have my screen. Yeah. Okay, so good afternoon, everyone. It's a pleasure to be speaking to you on this very important topic, which is really an integration of two complex issues here. One is self-harm and the other is the issue of violence. So my presentation is going to focus on three things. I will quickly run over this, methodologies that we use.
Veena ma'am, can you please switch on the slideshow?
Yeah.
Thank you.
Sure. So we'll talk about some ways to assess, to identify who may be at risk, and then we will talk more about individual interventions and also systemic interventions. I think Dr. Aruna's talk has made it very easy for me to run through some of the initial slides. She gave a comprehensive picture of risk factors. And I would also like to highlight here that women exposed to violence are at an increased risk of self-harm behaviors, both non-suicidal self-harm as well as suicide. And if you look at this table, you see a lot of risk factors for suicide having considerable overlap with the experiences of violence survivors. For instance, cognitive effects of trauma and stress on decision-making, we know that impacts both violent survivors as well as is a risk factor for suicide. Helplessness, mental health conditions, pretty much emphasizing the role of depression, but also sometimes anxiety disorders and PTSD. Barriers to seeking help and accessing services is there among IPV survivors as much as it's there among people contemplating suicide, social isolation, and also prior suicide attempts we see in survivors who report violence, as well as those who may be at risk for committing suicide. So we said that self-harm behaviors exist on a continuum. On a one end of the continuum, you have non-suicidal self-injuries behaviors, let's say, and on the other end, you have suicide. What is important is to understand intensity of intentionality as well as lethality. So intentionality is really this willingness to die and the intent to die, whereas lethality is the choice and the severity of the method that you use to end your life. So both of this play a very important role, although I would like to specifically highlight that seemingly non-lethal behavior should not be taken lightly because they are also a signal of distress, and this may also put the woman at future risk of suicide and self-harm. So what seems like a non-lethal attempt or non-lethal self-harm behavior today could still be a risk factor for something more severe later. One of the myths that we often speak about is whether asking explicitly about self-harm, puts the seed in their mind, and as a result, am I sort of giving them ideas and are they likely to engage in these acts? It's also important to remember that that is not so. It's very important to give the woman the space to talk about these matters that are so private and so personal, and she may not have had a chance ever before to share this or make this disclosure to anyone else. So it's also seen as an effort to reduce their anxiety, clarify their myths, clarify associated thoughts and acts of self-harm. It also helps the lady feel understood. However, it's very important to remember that this should always happen against a good therapeutic relationship or a good doctor-client or a helper-client relationship that you have established. So quickly to talk about screening, because it's very important to identify among the bigger pool of women who might be most at risk. Some of the commonly used screening measures are Columbia Suicide Severity Rating Scale, which could be administered by anyone. There is also a screening measure used quite frequently in the US, which is called Ask Suicide Screening Questions. And there is a patient health questionnaire that we use for depression predominantly, but does have a question on suicide. So a lot of Western guidelines say that all IPV survivors should be screened following a major event, but it's not just following a major event, and these assessments are not a one-time thing. It's important to understand that a woman today may not have such ideations, but when you evaluate her 2 weeks later or 1 month later, she could report that she's been, thinking about death and dying, and this thought about ending one's life crosses her mind. So this has to be, done periodically at regular intervals to be able to identify women who may be at risk. So after having done a quick screening, sometimes it's very important to refer them to mental health specialists who may carry out a more in-depth evaluation through a clinical interview. Through that, it may sort of clarify if they sort of meet criteria for a diagnosis or multiple comorbid diagnosis, and it may also help us make a treatment plan which sort of addresses all of these host of risk factors and comorbid clinical conditions that a woman may have quite comprehensively. So how do we screen for suicide risk? It's very important to use an algorithm sometimes which just helps you introduce this topic. So why are we talking about self-harm to women experiencing violence? So we may want to start with a question like this, which says, because people in your situation often feel depressed or hopeless, it is something we ask everyone about. So to tell them that this is not just a question that is being asked to you, but because there are so many people in these very circumstances, it becomes important to ask these questions of everyone who's experiencing this kind of adversity. And then we move on to specific questions about self-harm itself. So these questions could look like, in the past few weeks, have you wished you were dead? in the past few weeks, have you thought, or has anybody in your family thought, that you were better off dead? In the past week, have you had thoughts of killing yourself? Have you ever tried to kill yourself? If so, when? What were the circumstances? How did this, really take place? Can you please tell me a little more about it? So, if there is a yes answer to any of these questions, it would be important for us to follow up with evaluating their safety, making a safety plan, and all of us needs to have a protocol for first response. So this disclosure has happened to you in this assessment setting. How do you respond to it? And I'll talk a little more about that when we come to individual level interventions. But what is more important is to also quickly evaluate if the risk is acute. What do we mean by this? Are you having thoughts of killing yourself right now? Can you tell me a little more about it? In this context, we can assume that it is acute, and so it becomes very important to keep the person in sight, be vigilant, remove all dangerous objects from their reach, notify someone who is trained, who can provide first response, who can do a quick psychological first aid. Sometimes it becomes important to loop in family members or a close confidant who the patient or the woman is willing to involve in their care. So American Psychiatric Association has also given guidelines for suicide assessment, and they say that this is also something that needs to be conducted in every interaction with domestic violence or intimate partner violence survivors. However, it should be done against the setting that ensures privacy, that ensures confidentiality, that you have interpreters in case language is a constraint. You explain to them the rationale for why an assessment like this is being done on them, so that it reduces fear, anxiety, and also the risk of aggression, and sort of settles very intense emotions that these people will likely experience. It's very important to also tell them what is likely to follow. In the next half an hour, what are the kind of questions you will be asking? It gives them a sense of control, a sense of agency, which also reduces fear and anxiety in them. It helps them participate in this help-seeking process better. It helps them engage better. What is also important is we know that people who work constantly with self-harm survivors or with violence experience a lot of secondary trauma. So it becomes very important to debrief staff involved in this process. Now, screening for non-suicidal self-injurious behaviors are not as straightforward as screening for suicide, because the nature of these acts can be quite heterogeneous, and to always clarify very clearly whether there was an intent to die or not, whether it was lethal or not, can be, sort of a little murky. However, it's still important to ask whether you've hurt yourself on purpose. How do you typically hurt yourself? Do you do this by cutting, slashing, burning yourself, biting, scraping your skin, or erasing your skin to a point of drawing blood, which means rubbing constantly over certain skin areas, even though they are tender, to cause some kind of an injury, which ultimately results in, blood. What is also important to ask about frequency, not in an insensitive way, but to say, how often do you see yourself doing this, maybe in a span of a month or a few weeks? And when we talk about evaluating level of risk, it's always important to be alert to red flags and also green flags. Red flags here talks about risk factors, and green flags talk about protective factors. So you can see some of the red flags of hopelessness, despair, people who have thoughts currently about harming themselves, signs of, previous attempts of poisoning, intoxication, bleeding, self-inflicted wounds, loss of consciousness, lot of lethargy and isolation. All of this indicates that this woman is not in a position to care for herself, which means that we need to do something more and also involve her support system to do a little more and to be vigilant. The green flags could mean having a good support system, that this woman is able to function well, goes to work, has a routine, has very big reasons to live, such as children, elderly parents that are dependent on her, she's caring for them. Religion and spirituality sometimes, which sort of stigmatizes self-harm, can in this case be a little protective. um, Hopefulness and resilience is always very important. So always when we provide services, we look at it as a stepped care approach, where a lot of people will require educative, preventive interventions. But as we go up the pyramid, a few people may be at greater risk who will require more specialized interventions. So with that, we come to individual level interventions. And here I would like to highlight the role of psychological first aid, making a safety plan, talking to them about more specialized interventions, and also using a feminist lens to be able to discuss some of these challenges that women in patriarchal cultures go through more, which Dr. Aruna also alluded to. So just like we use a first aid kit for a person who is physically hurt, we use psychological first aid, which is a humane approach, which is very supportive. It involves mobilizing resources, giving practical assistance to people who have had various kinds of interpersonal traumatic events, or even non-interpersonal events such as natural disasters, road traffic accidents, and so on. Right? The goal is to address immediate emotional distress that it triggers, and also to prevent adverse consequences such as self-harm in this context also. So the WHO has proposed a very important psychological first aid paradigm, which is called the LIVES approach. It is an acronym where L stands for listening, I stands for inquiring about their needs and concerns, V stands for validating their emotions, E for enhancing safety, and S for supporting them. So when we talk about listening, we are emphasizing the role of active listening, but also empathic listening, and giving them a space where they can sort of talk freely about their concerns. We are listening to what is verbally said, but also non-verbal aspects of communication become important here. We inquire into their needs and concerns because we need to understand what are their needs, what are their priorities. Please ensure that we put them at the center of this, so that it's not really our needs or our priorities, but it is really coming from them. Validating is a very important aspect of acknowledging this lady who may be in great distress, to demonstrate that you genuinely care, that the distress in this given context is very understandable, and anybody who goes through these kind of challenging circumstances or adversities is likely to feel what they may be feeling, without making them feel guilty or without shaming them about what they are feeling, because there is nothing right or wrong about the kind of emotions they are experiencing at this point in time. So in no uncertain terms, it's important to convey to them that this is not their fault, right? Enhancing safety becomes an important goal, whether we are talking about self-harm or about violence. And so creating a safety plan becomes important, and I'll talk about it a little later. And also difficult and complex and mixed emotions such as guilt, shame, requires some support, and it's very important to ensure that they sort of remain engaged in this help-seeking process. So when we talk about safety plan, it's about customizing a plan that works for a given woman, right? So there may be general guidelines about keeping harmful objects out of reach of self and also of the spouse. Self because, it could be used for self-harm. Other because it could be used for violence. It's also important to talk to the woman to keep all her belongings in a bag. So this could be identity proofs, degree certificates, money, medicines, documents concerning the children. All of it needs to be either put away in a place which only she has access to, or given to somebody, a close confidant of this woman who can keep it safe for her. Right? It's also important to tell them to keep important contacts on speed dial, to also educate children, make them aware about a signal you may be using, such as the word red, which indicates danger, which indicates that it's time to call all of this into action. In case they are leaving home, then it's also important to tell them that she shouldn't disclose her whereabouts to a lot of people. It's only to be known to one or two people who she thinks she can trust, who will keep it safe. So in terms of psychotherapeutic interventions, these are more specialized interventions which are conducted by mental health professionals with some amount of training, where we have psychiatric conditions such as depression, anxiety disorders, or in this case, PTSD, post-traumatic stress disorder, or complex PTSD, which is really in the focus. And some of these kinds of therapies are known to help people who have PTSD, and these are all evidence-based therapies. So this is just to give you an overview. I won't be spending too much time on these. Coming to feminist principles of counseling, very important to explicitly have a discussion so that the woman is able to also acknowledge unequal power relations among genders, while giving a space of safety and validation, and avoiding victim blaming or shaming, and not endorsing harmful stereotypes that, you know, marriage is for good, it is a lifelong commitment, so there is no question about thinking about leaving this relationship and so on, and marriages are safe. So to stop perpetuating some of these myths, to communicate, understanding, accepting, and also empowering them by respecting her agency. So this is a very strengths-based approach where she takes on her agency to be able to make the choices that she thinks are important, and also to focus on consciousness raising regarding violence as a social issue and not as a personal fault. So whenever we are talking about adversity and traumatic events, emphasize the context and not the person, right? So what are the kind of interventions for people with risk of self-harm? Three things that are constantly emphasized are mobilizing psychosocial support from trusted contacts, addressing distress through first response, making referrals to mental health professionals, and definitely maintaining follow-ups, because you know you've told a lot of women to consult these people, but it's important to follow up to see whether or not she has done that. Are there any barriers to reaching out to these people you have referred them to? How can you possibly address those? So these are some guidelines that becomes important where there is imminent risk of self-harm, and that is to remove objects that could be unsafe. Important to supervise and monitor, regularly check on them. Yourself or a close confidant can do this. Provide psychological first aid, provide a bit of psychoeducation if you feel there is depression, anxiety, and other conditions emerging. Encourage helpful coping strategies such as relaxation, maybe taking some time out to go for a walk, distraction, and all of that. Encourage help seeking from mental health specialists. Follow up and make sure there is a safety plan in place. And wherever more serious acts of self-harm is in the picture, evaluate whether they need a health facility. Even in the health facility, make sure they are not left alone. If a hospitalization is needed, make sure monitoring and suicide prevention strategies are discussed. Psychological first aid in the healthcare facility also becomes very important. Mobilize other forms of support that may be available. See if a referral to a mental health professional is necessary. Make an assessment, a detailed evaluation, and a treatment plan. Follow up and make sure there is safety planning done for post-discharge safety of this particular woman. What do we do in terms of aftercare for suicide attempters? Very important again, for us to communicate in no uncertain terms that we are here to help them and that we understand their distress, that we want to help them. Ask them what kind of support they need from you, right? So give them a chance to tell you what they want from you. Be supportive, not just in what you say, but your body language, your tone of voice, and all of that. Use respectful language, very important, and we are all constantly learning from our mistakes. So I'm guilty of saying commit suicide, but now I consciously tell myself to say attempting rather than committing, because it implies a crime, right? Give them some time and space. Not every silence needs to be filled. Sometimes silences are important. It allows them to process so much that has happened, and give them time for that. Some things that we should not do is dismiss, like I said, non-lethal attempts as saying that this was done just for attention seeking. Don't be insensitive with questions. Don't ask too many leading questions, curiosity questions. Ask yourself, is this really relevant, or are you asking out of your curiosity, right? Don't rush to make them feel grateful for all the things and shame them for having attempted. And don't compare their situation with somebody else and make their pain and distress seem bigger than theirs, because that, could minimize the kind of distress that they may be experiencing. So, how do we care for women who are self-harming? Psychoeducation about self-harm and suicidality becomes very important. And it's important to tell them that these are expressions to manage their distress, manifestations of distress in stressful situations. Important to talk to them about management strategies. These could be relaxation, distraction, like I said, reasons for living, moving to a safer environment. A bit of environment manipulation also becomes very important. And sometimes, when you can't completely avoid it, harm minimization strategies. So instead of banging your head against the wall, can you just punch a pillow so that you don't hurt yourself too much, right? Can you grip an ice cube so that you experience the same numbness that you want to experience? And leaving them with emergency numbers and support, hotlines and helplines become very important. I thought I'll make a quick mention here about postvention also, because a suicide loss is almost always very sudden and therefore very devastating, confusing, and traumatic to people who are left behind. So, community members, loved ones are all in this together. So, very important to make some first response interventions for them as well. Very important to think of this both in the short term as well as in the long term. And there are very many survivor support groups and programs, so to probably link them with some of this. Please remember this very important point that postvention is also prevention. These people are in great distress and they may have an increased risk of suicide themselves. So postvention offers support and healing to reduce suicide risk later, right? So we quickly move on to systemic interventions, and I want to talk about trauma-informed care a little bit. We all know about traumatic experiences which are very intense and affects multiple domains of our life. Therefore, trauma-informed care is a very strength-based service delivery approach which focuses on understanding and responsiveness to the impact of trauma and rebuilding the sense of control and empowerment, right? And therefore, unnecessary policies and practices of institutes can be avoided because you're trying to prevent re-traumatization from taking place, and you plan survivor-led initiatives, include this woman in planning the development of this intervention, delivery of this intervention, and also evaluating services that we have ultimately put out for people like her. So make them a part of what you're trying to develop for them, right? So SAMHSA and a lot of organizations talk about these key ingredients. I know a lot of you are from NGOs, so make sure that your organization is involved in practicing this, leading and communicating, creating awareness, engaging individuals in planning your services, training all staff. Doesn't matter if they are only a security personnel, they still need to know, because the person may approach them first. Create a safe environment where you offer these services, prevent secondary trauma or vicarious trauma from taking place, build an informed workforce about trauma, about suicide and violence and so on, involve the patient in this treatment plan that you're making for them, which is very customized, screen for trauma, use trauma-informed treatment modalities that are available, and engage with stakeholders. So whenever we deal with self-harm and violence, let's remember that it's not a one-man, service. It is a multi-pronged approach which brings together medical, legal, social, all of the stakeholders. And so we do this with the attempt of minimizing re-traumatization, which is nothing but making the lady go over their very painful and difficult story over and over again to multiple different people in the system, which also then makes them feel very powerless, right? So some of the important examples, which gives us an idea, is to have women officers as the first point of contact for a complainant when they go to a police station, right? So it's not enough that they are a woman, but it's also important that they are sensitized, correct? Recording a survivor statement or a victim statement in their residence or a place of their choice where they feel safe rather than coming to the police station, right? Mandatorily seeking their consent for medical evaluation. Again, I want to say a thing here about consent, that it is an ongoing process. It's not a one-time thing, right? So I can't assume that because I'm married, then there is consent given lifelong for different kinds of sexual acts that are likely to take place in this marriage. Similarly, when I take consent for assessment, I can't assume that all components of my intervention or treatment or follow-up is all covered, right? So consent needs to be taken at various different stages. So NIMHANS, under the leadership of Dr. Prabha, offered psychological first aid training and mental health care and psychosocial support training to all the staff and counselors of one-stop centers all over India. And these kind of efforts are required for systems strengthening. Now, many of you may have heard of gatekeeper programs. Again, very important to train ourselves in this, because all of us can potentially be gatekeepers. So it could be a hostel ward, that this is increased, and therefore their services also became better. So I want to end by saying suicide prevention is everyone's responsibility, whether it is media and responsible reporting, our policies and practices, selling of very lethal prescription medicines and pesticides over the counter, eliminating and destigmatizing some of these myths and attitudes around self-harm and violence, and finally liaising in an effective manner with all stakeholders to reduce re-victimization becomes very important. So I'm going back to the theme of this year's Suicide Prevention Day, and that was to create hope through action. But here, let's create hope through our collective action. Thank you very much.
Thank you, Dr. Aruna and Dr. Veena, for such insightful sessions. Now, if it's okay, we'll take up some questions.
Sure.
Dr. Aruna, this question is directed to you. What are the protective factors? Dr. Aruna?
Yeah, am I audible?
Yes, ma'am. Yes, ma'am.
Um, when it comes to a specific group of people who have victims of violence and self-harm, searching for protective factors is a little bit difficult, but still having young children, and there is something called looking over the shoulder kind of thing. So even people who have been self-harming themselves, they wouldn't want to do it in front of their kids or say in front of their young children, especially if they are of the same gender. That could be one of the protective factors, where they wouldn't want their children to emulate their behavior in the future. So how much ever they feel justified for their self-harm behavior, they wouldn't want their own kids to do it. So having children could be one of the protective factors. Having family support, probably a good family support, could prevent them from going into such kind of things. Having people who understand them or who are good to them rather than good people. Surround yourself with good people is what we say all this. But surround yourself with people who are good to them. Probably that would help them or act as protective factors. A lot of empowerment in the way of economic empowerment, or giving them more choices. As I said, it is also an indictment on our culture and society that they are left with no choice but to self-harm themselves. So, expression, a better way of expressing these kind of things, if is their facilitation, then probably it will act as a protective factors. As you said, the risk factors are studied much more than the protective factors. But just like the protective factors for suicide, what we have studied, having having children or this, being married, it has a different kind of suicide risk pattern there. It acts as a protective factor for men, but it is not such a big protective factor when it comes to women. So there is a gender bias in telling that marriage will act as a protective factor against suicide or against self harm. Whereas in suicide, it has a clear cut gender differentiation also. Probably being in a better, higher socioeconomic status, being better educated, having more resources at hand, having young children at home, having somebody who really needs your care, and having dependents in your thing. Maybe these factors act as protective factors. Yes, it is not as much studied as risk factors also. That much we can say as of now. Maybe Dr. Veena or Dr. Prabha can add to it. Protective factors when it comes to self-harm.
I think you've captured it all, Aruna. I completely agree with you that not as much research, but all the factors that you have mentioned are important.
I think I also mentioned in my slide some of the red flags and green flags, and I was using green flags to suggest these protective factors. But sometimes it can become a little challenging. Having children sometimes make women remain in abusive relationships. But having children could also be a protective factor for self-harm, right? So that's the reason, that's a strong reason to live. So sometimes we need to not look at it, as a very watertight thing, but see how it's working for a particular woman, right? That also becomes important. Thank you.
Dr. Veena,
Here,
yes, ma'am. Yes, ma'am.
here I would like to add a caveat. There is a category of women who would consider children to be part of them rather than considering them different from self. So those people who are intending to harm themselves or commit suicide, they may first harm the child or try to kill the child, then kill themselves. So it becomes when they think that the child or taking care of the child is totally their responsibility. So they would want to, tie all the loose ends. And in tying all the loose ends, the killing of the child also might become a factor. So we recently had a case where a young woman with severe depression and psychotic symptom ended up disrobing herself, putting all her clothes over the child's body and just drowning the baby. And she was found naked sitting near a pond after some 45 minutes. So she told that, it is I am punishing myself. I love my child and I killed it to punish myself. So these kind of things, though we say that it is, protective factor, sometimes it may act against also. So it is not like watertight, having children will protect you from self-harm. Probably yes, but certain circumstances, it may be counterproductive also.
Dr. Veena, the next question is to you. Mr. Rajendra Meher is asking, is there any specific therapies for which deal with helping developing healthier coping strategies for individuals who are going through self-harm and emotional pain?
Yeah. So I think all of what I mentioned under individual level interventions, which is necessarily for alleviating distress and improving their adaptation of these women in distress that we see who are facing violence and who probably also have self-harm behaviors, can be, considered first level therapies, the psychological support, the psychological first aid that I mentioned, the lives approach, right? To also use some basic micro counseling skills to, offer a safe space for this lady to make that disclosure, for you to get an opportunity to address that disclosure well, to treat her with respect. All of that initial, what may seem like simple steps, will go a long way. And then comes a few women who probably require to see a mental health professional for more systematic evaluation and treatment. And then comes, with that, more sophisticated and structured psychotherapies like trauma-focused CBT or narrative exposure therapy. Eye movement desensitization and reprocessing has become very important for people with PTSD. So then, it's an endless list. But all interventions and all therapies are with the goal of alleviating distress and improving their coping, isn't it? Improving their adaptation with the circumstances that they are in. So we just need to see for the extent of distress, whether just first response is adequate, or if you feel that this person is depressed, has PTSD, then something more may be required. If the person has a personality disorder, more long-term treatments may be required. So that's why conceptualizing along that stepped care framework helps us decide what is the kind of dosage of intervention or treatment that a particular woman will benefit from. I hope that answers your question.
Thank you, ma'am. As a follow-up to that, Mr. Kiran Kumar asked that how do we ensure to keep the patient in loop for continuous therapy? Because once they start feeling better, they feel that therapy is not required and they drop out of it. So how do we ensure? So any inputs on that?
I think that's a very, very important question. It is also something that everybody working with distressed women struggle with, right? Because you make one of the best plans, safety planning and treatment planning, keeping in mind all the risk factors and ongoing violence in mind. But what if she just does not show up after the first session? So one of the important things to do is to make every session as complete in itself, to leave the lady with resources that she may not want to activate now, but may want to wait and activate later, but at least you've made her aware of these resources, to make her aware that this is going to need some time, right? She's been living under these circumstances for a very long time. So she needs to also give us a little time to help her with the kind of emotional manifestations she's showing. So to prepare her for the kind of time that this is likely to take, the number of times she is likely to have to come for these therapy sessions, all of that also has to be made clear to her. Despite your best efforts, sometimes people do drop out, not because of you, or sometimes maybe they felt that our approach was not sensitive enough, or whatever could be the reason, but sometimes because of genuine hardship that she has. Accessing your service is difficult because she lives very far away from your center, right? So offering other mediums of support, like maybe, option of texting, option of phone-based contact, option of online contact when it's impossible for her to come face to face, giving her, flexible alternatives to choose from, I think becomes very important. I think the pandemic has taught us a lot of these lessons, which continues to be relevant post-pandemic, right? So we need to really try and ask ourselves, have we done everything that we possibly could? And despite that, if there is a dropout, I guess, it leaves us with a little bit of helplessness, but I guess we need to understand that we also operate within certain boundaries and limitations. Thank you for your question.
Thank you, ma'am. Dr. Aruna, this question is for you. Mr. Kiran Kumar wants to know why some women have difficulty in expressing their emotions.
Uh, uh, I read that question in the chat box and I was wondering, why some people have difficulties. It's as good as asking why some people have no difficulty in expressing themselves. So, it happens to be that individuals are not able to express as they are based on different things. One is their personality, their attitudes. Are they a very, extrovert kind of person, or they are a kind of private persons where they would like to keep their thoughts privately. Other thing is also culturally and societally, how much are they allowed to express? See, we live in a culture where some people might be you can't sit like that because you have to sit in a ladylike way. How can you laugh so loudly? Because it is very unladylike. So even expressing expressions, rage, anger, these kind of things is taken to be a very thing that a man can do very easily, but a woman cannot do. And you because you are a woman, you are not supposed to show your anger that much. We put you on a pedestal because you are so patient. You are like the mother earth. So you are supposed to be all forgiving and not get angry and not express your feelings and all. So probably we are brought up in, some women are brought up in a culture that prohibits them from expressing what they feel. So expressing anger, expressing shame, expressing fear, or even expressing, what all negative things that they feel, not only towards themselves, towards others also. Probably these things are also suppressed culturally and societally also. No, the men around us may not do it intentionally, but it happens like a cultural thing. So probably they are not able to express it that way, and this seems a legit way of expressing themselves. Sometimes self harm, a cry for help. They can't if they wanted help and the help was available. Probably they wouldn't have resorted to this way of asking for help either. So some people, it is also both internal and external factors acting together, which makes us express our feelings. Some people are able to do it, some people are not able to do it. It happens that way. I think I don't know of a better way to put it. Maybe Dr. Veena and Dr. Prabha can contribute to it.
Ma'am, please unmute yourself.
Sorry about that. I think definitely Dr. Aruna made a lot of important points, but it also helps if I can, give you the way to remember the 4 trauma reactions using 4 F's, right? We talk about fight. We talk about flight, which is escape and avoidance, and fight is confrontation and, all of that. We talk about freeze in trauma literature to talk about the numbness that violence and all of this leaves you feeling. And then we also talk about the 4th F, which a lot of people are not aware of and is also important. And Dr. Aruna mentioned this in her presentation, and that is the fawn response, right? Where the survivor identifies with the perpetrator, starts looking at and starts justifying it, looking at reasons for why this happened, sort of condoning violence and so on. So it's also important to understand that expression of emotions can happen in very heterogeneous and diverse ways. Right? So we should also not expect that it will only come to us in this form. Right? It can take very many forms, and we need to be aware of all the different forms that it can take. I think this is a very, very important question.
Thank you, ma'am. Ma'am, one more question directed to Dr. Veena. How useful is it to involve the husband and his family when there is self-harm?
So this is again a very tricky aspect, and having conjoined sessions where there is violence needs to be done with a lot of caution, because sometimes if we have not prepared the woman enough to make this disclosure in the presence of the perpetrator, who could be the partner or spouse or mother-in-law that she has come with, it can cause violence to escalate. She can be put in harm's way, and it can make it very unsafe for her to be at home. So this is a big, big, big red flag, right? At the same time, if the woman requests you to do it and you have taken enough number of sessions and time to prepare her for all the pros of doing it and the cons of doing it, and she seems to understand the risks and she would like you to facilitate this discussion because she does not want to leave the relationship, but she wants the violence to stop, then taking a bit of risk, you will involve the spouse or the family members, and you will still do it in a very graded way, feeling their pulse, looking at their verbal reactions, looking at their non-verbal reactions when you address this issue of violence or self-harm, right? Now, self-harm also, a lot of people say keep it confidential, but one of the don'ts is to not get sworn into that secret pact, right? It is important to involve other people, right? If the disclosure has happened to me in the therapy session, I still need to involve my treating team and let them know that this person is actively contemplating suicide, because it is really safety at risk, and that is our number one priority. So whatever puts one's safety at risk, it is okay to have limits to confidentiality, privacy, and all that, which we uphold so strongly, and say and sort of educate this woman also to understanding why you want to discuss this with a family member, or why you want to discuss this with a member of a treating team, and to tell her that this is all being done keeping her safety as the priority, right? So then she may be able to understand, while you're still keeping a lot of things confidential, you may have to disclose this to certain other people in the family or in the treating team. Thank you.
Thank you, ma'am. This will be the last question. Ma'am, it'll be to Dr. Aruna. Any assessment tools and inventories or any books that you can suggest for our participants today to read more about self-harm in women, domestic abuse, violence?
Assessment tools, I think Dr. Veena had put in her presentation very nicely, so I would want to repeat it. There are many screening tools, and this about the books, what you can recommend it to read is, while I went through all this presentation part, I came upon chapter of
Hello, ma'am. Sorry, I think there was some problem with the internet, ma'am. We missed the con. Hello.
Hello, am I audible?
We missed a huge chunk of your speech, ma'am. Can you please repeat the books?
One of the books or one of the chapters which I found useful was one author who has written a whole chapter on understanding self-harm in women. So, Hannah Pickard is her name, HANNAPICKARD. So, if you type that, where she writes about self-harm as violence and where victim and perpetrator are one. It comes in one of the chapters of that book that I found quite useful while researching for this topic. One more book which I will try to show it here. I don't know whether this can be seen here. This is a book even where Dr. Prabha has, is one of the editors. I think Dr. Meena also has contributed a chapter here. This covers almost all aspects, preventive aspects, and what do you say, of preventive aspects, and also the thing about self-harm. So this is about suicide by self-immolation. So since self-immolation is a very violent way of self-harm, probably in this about the trauma, the adversity, and what I found nice about in this book is the neurobiology behind, which links all the trauma with the self-harm and suicide pathway. So there are n number of books. I don't know. I mean, I studied it academically. So to suggest academical things, you will get a chapter on self-harm, on suicide, and all psychiatric textbooks. But if you want specific things, I think as we go along, I pick up some books and read to offhand tell about it. Maybe Dr. Veena can tell better, I feel. I think Dr. Krishma has also put it in the chat box. So those things also are good enough.
Yeah, I think these are good resources, and we can probably share this with the participants.
Ma'am, thank you for a wonderful session, Dr. Aruna and Dr. Veena. I would like to now hand it over to Professor Prabha Chandra for concluding remarks.
So, the success of a session is the amount of discussion it generates. And clearly, there are so many questions which are still unanswered. I was trying to type some answers in some of them. Many of them got, answered. So thank you, Dr. Aruna and Dr. Veena, for this wonderful session. Clearly there are no definite answers for many things. Women who are going through domestic violence struggle with their emotions, not knowing what to do. Many times it's helplessness. Very often we put them in a corner saying, you should tolerate the violence. This is your life now. And that clearly, puts them in a spot where sometimes self-harm is the only option. So I think you have raised some very, very pertinent questions. There are lots of appreciation in the group. And thank you very much. And thanks to the audience for joining in. We hope to have many sessions going forward, and we will keep you in the loop. The next session, which is planned, is related to cyber violence against women and its impact. So please watch this space and tune in. Thank you, Dr. Aruna, and thank you, Veena.
Thank you, ma'am.
Thank you everyone for participating in today's session very actively. Like ma'am said, we still had a lot of questions, but we tried to address most of it. I would like to just take this opportunity to thank our main funders, that is the State Government of Karnataka Department of Women and Child Development, and also NIMHANS Digital Academy for their technical expertise. With this, we'll conclude the session today. Thank you all. Hope to see you again in the next session.